Hospital, UAMS, in pediatric endocrinology. I have no financial disclosures, no financial commercial interest to disclose. So the objective of this talk is to identify kids who have early puberty as well as late puberty, and discuss common causes of early and late puberty, and then discuss which kids need referral to endocrinology. Okay. So starting with what is puberty? So puberty is a stage of growth leading to sexual maturity and reproductive capacity. In girls, the first sign of puberty is breast development, and in boys, it's testicular enlargement. Now, puberty is governed by multiple factors. We don't really know what really causes onset of puberty, and there are genetic factors, nutrition factors, environmental factors. And as Dr. Oden said, diets have been changing a lot, and there's lots more fast food, and obesity can sometimes drive bone age and lead to early puberty, especially in girls. Just to digress, when I was growing up, when I was like 9 or 10, my mom took me to the physician because I was underweight, and then by 17 or 18, I was overweight. I went back and looked what changed. I grew up in India, and I saw that when I was 9 or 10, the first McDonald's opened in India. And I think that's the cause of me being a little bit overweight now. So that can also affect obesity. So as you see, the genetic factors affecting obesity, not obesity, puberty, are quite not so complicated, I guess. There are multiple factors, so it's very, very hard to understand what exactly, triggers puberty. There are multiple genes involved. The final common step is to have pulsatile GnRH secretion, because GnRH, or gonadotropin releasing hormone, if secreted in a pulsatile manner, that will lead to onset of puberty. It's important, the word pulsatile is important because if you have a constant amount of GnRH, then your puberty will not be triggered. So going back to first changes of puberty in girls, so Tanner staging. So breast, at stage 1, they are prepubertal. As you get to Tanner stage 2, there is budding, there is larger areola, elevated contour. At stage 3, there is further enlargement of breast and areola. And at stage 4, there will be a secondary mount of areola and papilla. And stage 5, there will be mature breast. So this is kind of a picture which shows you, stage 1, there is prepubertal. Stage 2, there are breast buds formation. Stage 3, further enlargement of breast, and now you start having, in stage 4, you start having projection of the areola and papilla to form a secondary mount, and then at stage 5 is basically adult breast. So stage 2 is basically onset of puberty. And similarly, this is similarly pubic hair in girls. So prepubertal, you will have no pubic hair. Then at Tanner 2 stage, you will have some amount of pubic hair, mainly on the labia. And then stage 3, it gets darker and coarse and spreads more over the mons pubis. Stage 4, you will have more like a triangle, adult-shaped kind of pubic hair. And at stage 5, you will have spread to the inner thighs also. So that really is, stage 5 pubic hair. And as you see, other changes that may happen in Tanner stage 2, you might start having an increased growth rate. At Tanner stage 3 in girls, you tend to have peak growth rate, and then at Tanner 4, you might even have onset of periods. Similarly, in boys, this is the Tanner staging for boys. For pubic hair, stage 1, there is no pubic hair. Stage 2, there will be some sparse pubic hair at the base of the penis. At stage 3, it becomes more coarse. At stage 4, it becomes more dense, starts looking more like an adult kind of pubic hair, and in stage 5, again, it spreads to the inner thigh. And then the testicular volume, usually less than 3 cc's, is considered prepubertal testicular volume. So if your testes start measuring like 4, 5, 6 cc's, that means you have started puberty. So again, in different stages of puberty, you will start seeing that the testicular volumes keep increasing. So this is an orchidometer. This can be used to measure testicular volume. I think this is probably an endocrine vital sign. When someone tells me heart rate, blood pressure, I'm not interested in that. I want this. I want the testicular volume. So this is, I think, for me, an endocrine vital sign, and every outgoing resident should be given that as a graduation present, I think. So basically this has all the volume measurements, and then you compare it with the testicular size. And after a while you get experienced enough that you don't need this. So early puberty, now the next thing I'm going to talk about is early puberty in girls. So early puberty in girls is basically breasts or pubic hair before the age of 8, and menarche or menses before the age of 9.5 or 9.5. Now puberty can be central, which basically means that your brain is activating the puberty, or peripheral, that means there is some other cause in the body which is causing you to have puberty-like changes, but it's not really the activation of the brain hormones which is causing puberty. So central puberty can be idiopathic. In most of our cases, we will never have a reason. We will do an MRI and find the MRI looks completely fine. So we really don't know what's triggering the early puberty. But then there are tumors in the brain which can cause it. A lot of the puberty is under negative control in the brain, which basically means that when that negative control is lost, then you start having puberty. So a tumor which will, cause that negative control in the brain to go away will cause puberty to start. So tumors like hypothalamic hamartoma, optic glioma, pineal tumors, and then certain hormone secreting tumors can trigger puberty. Advanced bone age is an interesting thing. If there is a peripheral cause of puberty like CAH, congenital adrenal hyperplasia, which has increased your bone age to the point where now it's time for the brain to start puberty. Here, a peripheral cause of puberty can cause the central brain to become active and cause puberty too. So here you will need to treat both the actual cause of the advanced bone age as well as the central puberty. And then mutations of kisspeptin signaling, which was one of the genes in the genetic pathway which governs puberty. Now peripheral basically is something else in the body, not the brain getting active. So it can be an adrenal gland, so you can have congenital adrenal hyperplasia where you have a block in the formation of cortisol and or aldosterone also, and which can cause you to have too much testosterone production, which can lead to advanced bone age and pubic hair, armpit hair, other signs of puberty. There can be genetic mutations like McCune-Albright syndrome, where the ovaries has follicles and may secrete estrogen, which causes you to have signs of puberty. In these cases, usually LH, FSH, the hormones made in the brain will be low, because the source of puberty is a peripheral source, which will go and inhibit the brain. So the LH, FSH levels will be low compared to a central form of puberty. Neuroendocrine causes: if there is some kind of tumor making LH excess, if you're hypothyroid, high levels of TSH can mimic FSH and can work at the same receptors and trigger puberty. If there is any exogenous source of hormones, if someone else in the house is using estrogen and somehow the kid got the estrogen tablet or the patch or something, that can cause it. And the lastly is if there is any foreign body in the vagina or abuse or tumor, that can cause you to start having bleeding from your vagina. It may look like puberty, but it's more a local cause in that case. So investigations that you would do is obviously get LH, FSH, estradiol. LH, FSH tells you if it's central or not. It should be higher in central puberty, but again LH, FSH tend to change a lot during the day, so they may be higher in the morning and lower rest of the day. So it's sometimes difficult to catch a good value, and that's why sometimes we have to do something called as gonadotropin or leuprolide stim test, which is basically we give them a small amount of gonadotropin and see their response to that and see if their LH, FSH levels go high in response to the gonadotropin. So it's called leuprolide stim test. That's done sometimes to distinguish between central puberty, if you are in puberty or not, basically. Bone age X-ray tends to be advanced. Bone age tends to be advanced in puberty. 17-OHP, 17-hydroxyprogesterone, DHEAS, testosterone, if you are suspecting CAH. And in confirmed cases of central precocious puberty, you should consider doing an MRI. In girls closer to the age of 8, if they have no CNS symptoms, you may be able to skip it, but younger girls most definitely need an MRI to rule out a tumor. And more investigations will depend if you are looking for more causes, a pelvic exam, abdominal ultrasound if you're thinking of a tumor, or genetic testing if you're thinking a genetic cause for the early puberty. And then these are a couple of other tests you may consider. Leuprolide stim test, if you are not sure if the LH-FSH values are low because they are really low or because you did not catch them at the right point. And then ACTH stimulation test will help in diagnosing CAH or congenital adrenal hyperplasia. And these tests can easily be done in our day medicine center at Arkansas Children's Hospital. Now, if you have central puberty, what are the reasons to treat? If someone has central precocious puberty and does not have a tumor, otherwise it's idiopathic, there's nothing else going on, it is not necessary to treat them. It's not going to affect long-term fertility or any outcome if you go ahead and treat them. The couple of reasons to treat them is final adult height. Kids who go through puberty early, their bone age tends to be advanced, and then they stop growing earlier compared to other kids. Now, the earlier you treat the kids, the better is the height outcome. So this is one reason to treat them. In untreated kids, it was found that about 50% of untreated kids girls end up below the height of 5 feet, so about 53 to 59 inches, which is about 4'5" to 4'11". And then some girls may not be psychologically ready for puberty, like a 7-year-old or a 6-year-old may not be ready to have menses and be different from other girls in her class, basically. Okay. So treatment basically involves GnRH agonist therapy, and this is when I said pulsatile GnRH is needed for LH-FSH secretion. Here you give a 3-month, 6-month, or 1-month depot shot, which gives you a constant amount of GnRH in the blood, which will lead to suppression of LH-FSH secretion from the pituitary gland and suppress puberty. So pulsatile GnRH is what causes puberty, and you give a shot which causes a constant amount of GnRH. So you take away that pulsatility, and that causes your puberty to kind of be suppressed. You can also do an implant, which has to be changed once a year, a GnRH implant, which is Suprelin or Hystrelin. And then treatment of other conditions is based on the cause. So in CAH, they might need hydrocortisone treatment. McCune Albright, they may need anti-estrogen aromatase inhibitor treatment. And then there are books for parents and children to read in case how to deal with early puberty. So next is delayed puberty in girls. So what is delayed puberty? If you don't have breast development by age 13, or absence of periods by age 15, or you have no menses within 3 years of having breast development. So causes can be, first is anatomical, the ambiguous genitalia, anatomical defects in the hymen, vagina, endometrial adhesions, all of that can cause it. Next is ovarian causes, where there is something wrong with your ovaries. So in these cases, FSH is usually high, because here your ovaries are not responding to the hormones made by the brain. So the brain tries to increase the amount of hormones that it's making, so your FSH tends to be very, very high. So this can be, gonadal issues where genetic issues or gonadal issues like Turner syndrome, or if there has been a surgery where the ovaries have been removed, or post-chemotherapy patient which they've had chemotherapy or radiation, any of that can cause you to have ovarian problems. Now in central causes here, the ovaries are fine, but the brain is unable to make LH, FSH, and because of which you don't have puberty. So one could be just constitutional delay of puberty. You have a delayed bone age and you will finally have puberty, but you just don't have it right now. And there can be different causes of gonadotropin deficiency, like congenital, genetic, as well as acquired, if there is any history of brain surgery or radiation into the brain. And then there are other causes which cause called hypothalamic anovulation. These are usually caused because of other diseases which are causing you to not have ovulation. So obesity, pregnancy, Cushing syndrome, hypothyroidism, drug abuse, many other hormonal issues can cause you to not have ovulation, which will cause you to not have signs of puberty. So next set of figures are from the Sperling's textbook of pediatric endocrinology. I found them really good, so I thought I should not make my own. So these, I'm going to go through them a little bit quickly in the interest of time, but these are flow sheets to manage primary amenorrhea, secondary amenorrhea, as well as anovulatory disorders. So here, if you look at the primary amenorrhea chart, obviously history physical examination is most important in every girl, and then you want to see if there is breasts are absent or present. So because if the breasts are absent, then the girl really hasn't seen any estrogen, and it takes you down through a different pathway. Now, if the girl is underweight, you always think about eating disorders causing you to not have enough estrogen, and that's causing you to have amenorrhea. If the girl is not underweight, the weight is normal, then you look at LH-FSH. Now, if the FSH is high, then you're thinking about ovarian causes. So ovarian causes, any cause of ovarian failure like Turner syndrome, history of radiation, history of tumor. And if the LH-FSH are low, it could either be a central cause like gonadotropin deficiency due to genetic issues, radiation, tumor, or it could just be constitutional delay where it'll take a few years, but the girl will eventually have puberty. If the breasts are mature, then the girl definitely has seen some estrogen, so LH-FSH was active at some point, the ovaries did make estrogen at some point, so why is it not doing it anymore? So first thing is obviously check a beta-HCG, so a common cause of amenorrhea would just be pregnancy, so that's always rule out pregnancy. And then if the external genitalia is abnormal, as you see in the chart, then it could just be the ovaries are making estrogen, the uterus is there, but there might be a block in the outflow tract. And then going through this part very, very quickly, the testosterone levels, if they are high, it could be androgen resistance, which basically means that it's a 46XY male who has androgen resistance and now looks like a girl because the testosterone was not able to work at its level of the receptors, and now you have breast development. And a lot of these kids will come to light at puberty when they have amenorrhea. And then if testosterone is high, then it can be various causes of amenorrhea, could be PCOS, CAH. And if testosterone is normal, then you always want to rule out anatomical issues. Again, secondary amenorrhea, something similar. I'm going to skip through these slides a little bit because they are pretty much similar, where they talk about checking for HCG to rule out pregnancy, and then looking at FSH values to see if it's central versus peripheral cause. And so now if someone has delayed puberty and you find a cause that this girl will not be able to go into puberty, then basically we have to induce puberty in the girl so that she has normal breast development. So the way you do it is you do it very, very slowly. So you can use a patch or oral medication. So the patch which comes, if you see in the first few months, you will use a small patch and use it only for 7 days of the month. And then you keep using that patch for more and more days of the month, and then you keep increasing the dose after that. One other way to do it is also to cut the patch into pieces and then use a small part of the patch all through the month also. But a lot of people, especially pharmacists, don't like you cutting the patch, so sometimes they you have to write prescription in a different way so that they let you do it. The other way to do it is using oral estrogen, estrase, and starting at a low dose and slowly increasing the dose of estrogen. And after about 2 years of estrogen therapy, you will start adding progesterone so that you have cycling, and then you can switch the kid to oral contraceptive pills also to have irregular menstrual cycles. Patch versus oral treatment. Using patch is more physiologic. It bypasses the first pass metabolism in the liver. So someone who has high liver enzymes may benefit from a patch. And in older women, it was shown to have lower risk of thromboembolism. But disadvantages usually are, it's more expensive, not usually covered by insurance, and the protocols are actually more complex. Like if you're just using a patch, then first 2 weeks you'll use an estrogen patch, the next 2 weeks you'll use an estrogen plus progesterone patch, or if you want to use just an estrogen patch, then the last few days you might have to add medroxyprogesterone acetate by mouth. So that makes it a little bit complicated versus just using oral contraceptive pills after induction of puberty, where all you do is take the next pill, take the next pill, take the next pill. So I'm going to skip through that. So next I'm going to talk about early puberty in boys. So onset of secondary sexual characters in a boy prior to the age of 9 years. So again, here it can be central, just like girls, or peripheral, and the causes are more or less the same. So a central cause would be idiopathic in most of the cases, and then in some cases we'll find a tumor. There could be infections, history of trauma, history of radiation, chemotherapy, or some anatomical malformation in the CNS which is causing you to have early puberty. And peripheral causes again are similar to girls: CAH, McCune-Albright, testosterone producing tumors, other tumors producing hormones, exposure to androgens. Someone has gel at home, some males use gel at home which can come in contact with kids at home and which can cause you to have early puberty. So always ask if there are somebody in the house using hormones. And hypothyroidism, where high TSH can mimic some of the other hormones like FSH, which can cause early puberty. This can be seen both in boys and girls. Evaluation, always history, physical exam, growth velocity. Dr. Otero showed us some growth velocity charts. If your growth velocity is much higher than 97th percentile, then you're concerned about early puberty. Bone age X-ray, LHFSH testosterone for central puberty, DHEA 17-hydroxyprogesterone for CAH, and thyroid function testing. Other things you may consider, in a boy who has early puberty, always get an MRI of the brain. Central early puberty, always get an MRI of the brain. Other tests to confirm puberty might be GnRH stimulation test or leuprolide stim test, ACTH stimulation test for looking at CH. These tests can be done at Children's Hospital. And if you're thinking about a tumor causing increased testosterone, then a testicular ultrasound, abdominal ultrasound. Treatment again very, very similar to girls, using depot shots, implants, Implanon, Suprelin histidine implant. CH can be treated with hydrocortisone, McCune-Albright treated with anti-androgen therapy, and aromatase inhibitor therapy. Lastly, delayed puberty in boys. This is lack of testicular development by age 14 in boys. This can be again hypergonadotropic hypogonadism, which basically means that you are making high LH-FSH and your testes are not responding. So the problem is at the level of the testes. If you have high LH and FSH, genetic syndromes like Klinefelter syndrome, your testes did not descend, gonadal dysgenesis, history of trauma to the testes, radiation, chemotherapy, autoimmune, and other things. And then you can also have hypogonadotropic hypogonadism, which basically means that your LH and FSH are low. If your LH and FSH are low, then it means it's a central cause, it's a brain cause. So genetic defects can cause it: tumors, infections, history of chemotherapy, radiation, trauma to the brain. And then functional basically means that there is some other problem in the body. There is nothing wrong with your puberty axis, but you have some other chronic medical problem which is affecting your puberty axis and affecting LH-FSH secretion. So cystic fibrosis, asthma, IBD, celiac disease, and other endocrine disorders, diabetes which is not treated or poorly controlled, uncontrolled hypothyroidism, high prolactin, untreated growth hormone deficiency, Cushing syndrome can cause it too. Evaluation, we look at growth rate, Tanner stages, Testicular volume obviously will tell us if you have started puberty or not. Bone age X-ray, looking at labs, LH, FSH, testosterone to see where you are in the stage of puberty. Sometimes you may not have physical signs of puberty, but your LH, FSH levels are already going up, so you know that you might have puberty in the next few months. Other tests to consider: inhibin B tells you a little bit about testicular reserve and other endocrine hormones. Karyotype to consider: if your LH, FSH is very high, there is some kind of testicular failure, so always consider karyotype for looking at Klinefelter syndrome. And then similarly, you can do certain stimulation tests to see where you are in stage of puberty, as well as genetic tests. This is the growth chart that Dr. Otero showed, tells you about how you should be growing, and the blue line is for someone who's gone into early puberty, and the red line is for someone who's gone into late puberty. So it kind of guides you about someone's growth, as they're going through puberty. Management basically is, treating with testosterone, because for some reason the person is unable to make testosterone. So if there is constitutional delay of growth and puberty, here you just need to give the child a little bit of testosterone so that the brain axis becomes active. So testosterone about 50 to 100 milligram every 4 weeks for 3 to 6 months, and then stop it, and then see if the child is able to start puberty on his own. Other things, if you have permanent hypogonadism, then you need to start slowly at testosterone about 50 milligrams, and then increase it every 6 to 12 months to reach the adult doses. Other options are testosterone gel, which also has the advantage of bypassing the first pass metabolism in the liver, helpful for kids who have liver dysfunction. But again, you have to be very careful with this, because there are other people in the house who may come in contact with you, which can lead to virilization in women or young children. And there are other drugs which are hardly ever used for management. So take-home points is basically normal range of puberty onset in girls is 8 to 13 years. Puberty onset before age 8 is early. No breast development by 13 or no menses by 15 is late. So similarly in boys, normal age of onset of puberty is 9 to 14 years. Onset of puberty before 9 years is early, and no testicular enlargement by 14 years is delayed puberty. And I would recommend endocrine referral for every early and delayed puberty based on the above normal ranges. That's our contact information, and I think we're going to do questions in the end. Next will be Dr. Elizabeth Sellers, who is Chief of